Hi, I'm Dr. Rudra Mohan, and in the following video images you will see that we are planning to do an excisional biopsy by laser for a patient who had hailed all the way from Dharamshala, Himachal Pradesh. And now what we are doing is we have already achieved adequate anesthesia, and now we are just putting a tongue tie so that we can help retract the tongue. With the help of the retraction of the tongue, you can very well see and appreciate the initial anterior border of the white patch. The patient complained of a white patch which has been there for a very long time on the lateral border of the tongue and has been complaining of a painless growth that has not increased in size, but it is quite significant in its size and has caused the patient mental discomfort. The patient wants to get this removed so that they can at least be assured that it is not what they think they are, and under anesthesia we have started the procedure of the laser excisional biopsy. Now you can see that we are taking a little bit of the tissue lines which are separate. The margins are slightly separate from the actual margins of the lesion, because it is always better to take the sound margins of the sound tissue in order for us to compare for any dysplastic or metaplastic changes. As you can see, we are right now operating upon the anterior margin with the help of the laser. Mind you, for people who are sensitive, viewers who are sensitive but curious, viewer discretion is advised. We are right now excising the anterior margin of the lesion, the white lesion, which is under anesthesia, so the patient is not feeling any sort of pain. The only thing that the patient might be feeling is the fumes coming out. That's because a little charring does happen, and that's why we have placed this suction right next to the procedural field, so that the fumes of the charring is not appreciated by the patient. As you can see, we are now continuing and deepening the incision of the excisional biopsy with the help of the laser. We are using a diode laser. It's a soft tissue laser, and the beauty about this laser is that it does not have any side effects on any solid tissue. That means it works very well on oral mucosal tissue, because of the fact that this laser, the diode laser, is sensitive to pigments such as hemoglobin, and that's why it not only cuts, it also coagulates. So in the field of the procedure, while it is cutting, it is coagulating as well, and that's why it creates a relatively bloodless field, which makes the procedure very comfortable for the patient. On top of that, for the clinician, it saves us a lot of time. As you can see, we're using the tissue forceps to retract the tissue and trying for the deepest possible excision of the lesion, while preserving all the so-called vital organs, vital vessels. Because the tongue is a very muscular and a very vascular organ, we have to be very careful around the arteries. The arterial supply of the tongue is very rich, and that's why we have called in our oral surgeon, Dr. Prabodh Sen. Since the tongue is a very muscular organ, we have called in the best in the field, Dr. Prabodh Sen, who is an oral and maxillofacial surgeon, to conduct this biopsy procedure with the help of laser excision. And now you can see, you can appreciate that we are going deeper and retracting the tissue lesion, where we can completely take it out, excise it, and put it under the microscope for histopathological examination. And we can check if by God's grace it's just something non-cancerous, non-malignant, and we can dispatch the patient. Now if you can see that there is some bleeding, and that bleeding is expected, but because of the hemostatic nature of the laser, the bleeding is not as much as is expected with the help of a blade. That means with laser surgery, the beauty and the advantage is that you get a clearer field, because as the laser cuts, it coagulates as well, and you get a better field. Yes, there are some added advantages of the conventional methods which you will be able to appreciate in some time when we talk about the blade, because the blade will give much precisional cutting and incising because of the blade, right, the blade tip. And now you can see we are further retracting the tissue, and now we're going towards the posterior margin of the lesion, just to see if we can completely excise it out and not. So this procedure can actually take up from 40 minutes to 1.5 hours, depending upon how big the lesion is, how complicated the procedure can be in terms of vital organs and structures, and also depending upon the patient, medical profile. If the patient is, under, hypertension or anything of that sort, that kind of affects the complications such as bleeding. However, even before the procedure, it's standard operating procedure and protocol that we take all the blood reports of the patient so that we can deem the patient medically fit, and that's why we can undergo the procedure. If there are any antibiotics and anti-inflammatory medications that are required as a mandate, we give that while the procedure is happening and even before the procedure, so that the patient is covered when it comes to post-procedural inflammation or any sort of infection control, or basically coverage. Now, as you can see, we are using the laser to deeply excise, and you can appreciate the white lesion that is there. We have just removed the cotton and placed it again to pack and to coagulate the bleeding vessels and pack the bleeding areas, and now we are retracting it even further. Now, at this point of time, we were having a particular challenge, that was visual access to the laser and tactile perception because of the long filament of the laser. We were thinking what we need to do, because we need to get the sound margins of the lesion and the tissue margins as much as possible with the sound tissue also, so that we can compare. And we encountered some sort of bleeding. That's why we gave some further more anesthesia so that we could arrest the bleeding at the procedure site. Now you can see we have given the anesthesia and we started the excision, and now we did hit some maybe some arterioles or something, and that's why the laser has been used to coagulate the area so that we can separate and coagulate the blood out, because we won't have good access to the field. And that's where I come back and circle to the fact that we went old school when it came to making the procedure slightly faster, because of the fact that laser, despite the fact that it has a lot of advantages, it's slightly slower in terms of time when it is compared to a pointed, a number 15 sterile surgical blade. And that's why we decided for the posterior margin to go for an old school approach, the typical conventional approach that we'll use to dissect the margin, to dissect the actual final margin, to detach the tissue from the underlying tissue. We use the blade so that we can get cleaner margins, and then whatever bleeders that we get, we can coagulate them very easily with the help of a laser. Now we are suctioning, and at the same time you can see most of the tissue is almost completely mobile, and at some point of time it should just come out within a few seconds span. It will come out, and it has come out. Now this is the tissue that we sent for biopsy, and fortunately we found out that this tissue was Leukoplakia. Yes, a pre-malignant condition, but it didn't have any field changes such as any malignancy evidences were not seen in the biopsy, so the patient was very happy. It's been quite some time, it's been quite some weeks since the procedure was done. The patient has already been the stitches have already been they've gone off, because we were planning to give resorbable stitches, and we did give non-resorbable stitches as well, which they got removed at a local dentist in their native place. And now you can see Dr. Prabodh is using the laser to finally coagulate the bleeders which ever are present in the field. And it is very important, because for post-operative edema and post-operative infection, inflammation and swelling, it's always better to leave the site as bloodless as possible. So that's why we coagulated. And now we're using 4O vicryl suture. This is basically a bioabsorbable suture. That means it will go off, it will dissolve itself off by its own. And we did place a couple of non-resorbable sutures which the patient got cut at their native place. This is me and Dr. Prabodh Sen operating on the patient under local anesthesia. Thanks for watching.